joining us today for our webinar, part of our Critical Access Hospital webinar series. This will be on the topics of the Chargemaster, pricing transparency, and what does all this mean? I'm Amy Tepp, and I'm a partner in our Minneapolis office. I'm also the Director of Revenue Cycle Services for the firm, and I'm in our Minneapolis office. Just real briefly to go over what the learning objectives are for today. We're going to talk about the Chargemaster. We're going to talk about pricing transparency, and how these things are, similar but different, how they're interrelated, identify some best practices associated with these concepts, as well as how to optimize these for your facilities. So I just thought it would be good to start with just an overview of where these things we're talking about today fit within the revenue cycle. And this is just a very high level, interpretation of the revenue cycle. But basically, we see that we have the revenue cycle for the hospital in the very core center of this diagram. And there's things that go on in terms of governance and oversight around the rev cycle. It may be formalized more at your facility, or maybe just more informal. As part of that process, there's policies and procedures, and that's something we will be touching upon today as we move through the presentation. And then, there's also periodic assessment of things. We identify things that might have we're seeing increases in work queues, or just to do some ongoing monitoring. That's another thing that we'll be touching upon today. And the area that we are going to be focusing on is what I would call located in this revenue integrity box. And revenue integrity is a term that has kind of become popular in the last probably 5 to 8 years, and that's generally where you see the Chargemaster and pricing. Sometimes pricing's done in more of the finance side, but and coding somewhat can fit in revenue integrity as well. But it's like your charge capture, the Chargemaster, and pricing and validating that we've captured our charges. So let's just talk about the Chargemaster. So even Wikipedia has a definition for the Chargemaster. I think it kind of resonates with the current state of our industry and what you see. And, as we talk further through the conversation about pricing transparency, when you look through this definition, you can kind of see why maybe there's this hype around pricing transparency. So basically the definition, I don't think is too far-fetched actually, and it seems to be kind of in line with what people tend to think of, in terms of when we talk about hospitals and their charges. So it's basically the Chargemaster or Charge Description Master, CDM if you will, a comprehensive listing of items that are billed to hospital patients or their health insurance provider. It usually contains highly inflated prices at several times that of actual costs to the hospital. It also serves as the starting point for negotiations with patients and the health insurance providers of what amount of money will actually end up being paid to the hospital. And it's described as the central mechanism of the revenue cycle of a hospital. And as you saw in the previous chart, it's in the mid-cycle of the revenue cycle. So when we talk about the mid-cycle, we're talking about revenue integrity and the coding function. So all this sounds very important. So let's see why. So just starting from the very basics, the key elements are you have a department number, or it's actually like a revenue center, if you will. Sometimes it should really correlate to the expense side of things on your general ledger, but it may not always correlate, but ultimately it should be mapped as such. and then the name of the department, what the charge code is, the charge description, as well as the CPT code if it's something that we want to put the CPT code on. Most of the items have that, but there are some items that don't. HCPCS code maybe is what used in lieu of a CPT code. Sometimes we hard code modifiers in the Chargemaster. And then also the UB revenue code and the charge amount. And I've highlighted this charge amount in red because we're going to be talking about that later on in the presentation. So again, that's the focus of maybe that one item when we get to it later on. What I just sort of described as basic elements is kind of what those of us who've been in the industry for a while would kind of resonate with as far as your basic Chargemaster. Prior to the electronic health record environment, it was, people would say, I need my Chargemaster and I need revenue and usage information, and it was fairly easy to provide that information. But we entered this new, well, it's not so new anymore, but the electronic health record environment, and a lot of times with that, you were using the same thing on the revenue side. So, we use that, say it's a Epic or a Cerner or some other software product that the organization utilizes, and we use it on the clinical side, and then we've also adopted it on the revenue side. So some of the challenges and things that we have with the Chargemaster, and some of these things might be things you're experiencing yourself. Maybe you're part of a system and you're managed, and then you're utilizing their version of the software, or you're considered like in an affiliate arrangement where you've purchased utilizing another organization's electronic health record product. And there's some pros and cons to that. On the positive side, a lot of times the organizations that have that are like the owner of the main product have departments within their shop that kind of manage this area, the Chargemaster. So they'll make sure that the annual updates of CPT codes get taken care of in their system, because they need to do it for themselves as well. And they may also have a tool that they use to manage this process, and then as you need to add or modify things within your system, you utilize their tool to request changes to the Chargemaster. Some of the things that might not be the best is that it's very hard sometimes for this other organizations that are purchasing using their version of the software to request something different. They don't really want to do that because what you're asking them to do might impact another organization in a way that isn't optimal for that place. So they don't really, they kind of shy away from that, more customization type things. But they also have user groups too at the larger organizations where maybe all of the lab directors participate in some sort of a user group phone call on a monthly or quarterly basis, and where you can raise issues around things such as things that you might be seeing with charging, to have a conversation around that. We talked a little bit about Chargemaster tools. In some cases, the software that you might be using doesn't really lend itself, doesn't really have what you would call a Chargemaster. So you may have to look at other ways of managing it and maintaining it, as well as maybe even looking at possibly getting some additional software. There's various vendors out there that can be used to help with facilitating that. And then that kind of becomes your Chargemaster. The other things you need to be, cognizant are interfaces with clinical system. Where are some of these charges maintained? Sometimes these other systems like lab, pharmacy, they have their own system, and how does that get interfaced into the overall facility? Chargemaster. Some other considerations are charge routing rules. We've added more complexity now in how things get mapped, and then what is the source of truth for these things? Is it the main system that we're using, as our source of truth? So if you've run into situations where you're not understanding why a charge may not be dropping, or it's not routing to the right department, you might have to actually work with your IT people to understand, is there something going on with the routing rules behind the scenes to ensure that the charge is being mapped properly. Another thing to be aware of is, are we actually optimizing the use of our system? We've got this electronic system, and yet I see a lot of times where organizations tend to just we're just still using paper. We have paper charge tickets, and then we have somebody keying the data into the system. So you're really not necessarily taking advantage of some of the efficiencies with using this, electronic system. And, then there's some things where maybe some things are automatically dropping from a flow sheet, or there can be a combination of paper and automation used. It just depends. Sometimes you see that with some of the, one-off kind of things where we have maybe a contracted speech therapist might just fill out a paper ticket rather than have them get access to the system, and then somebody has to, at the facility, key that information in. And same applies with paper tickets, as well as things that are in the system that you click on and pick. As we're updating things, we need to make sure we update those things as well. Claim edits, and I have, beware of claim edits. I'll just use an example. I've talked about these charge routing rules. I've talked about the Chargemaster, and I've actually personally had a situation where we identified that we needed to change something. It was a revenue code, and we changed the revenue code in the Chargemaster. We had the routing set up properly so that it would have that right revenue code selected. And then then all of a sudden we find out, oh, the claim scrubber undid all that work that we did. So again, more things to be aware of as we're changing things, making sure there's not edits in that claim scrubber or elsewhere within the organization, and just connecting all the dots. And then the use of the encoder as well. One thing I wanted to mention too around charge entry, and I did mention about the speech therapist example where maybe they're on contract, or sometimes we do, we contract out, someone else is doing the sleep studies or possibly MRIs, just to make sure that someone's on top of all those little one-off type things to, make sure we get those charges entered into the system. We've also run into situations where something like that would be, I call it single threaded, where only one person in the organization, does that and worries about that. When then they go on vacation, or we find out they're on a medical leave, and we start realizing that, well, wow, we haven't had any, it's odd that the charges haven't come through. So if you have any situations that you might be aware of where oh, that might be something that we maybe need to have a backup plan for, something to consider. So another thing that we talk about when we meet with facilities in the around the Chargemaster is what are the department's responsibilities. So the departments need to see, well, we see anywhere from where the departments are understand that they own their charges, they're responsible for the charges in their area, to some departments where they don't really get the connection that they are responsible for the charges in their area. So some of the things that they should be cognizant of is that if there's a new service they want to provide or offer, what's the process at the organization to talk about what are the requirements, can we even bill for that service? And then once we determine, yes, it is something we want to do, and we can, that, how do we get it set up? How do we set up the charging mechanism within the system, as well as, getting it so we know that it's running through properly from the claim side of things. And then what the actual price is, and that we'll talk more about that later on. The other thing is that annually we know that the codes change, and so it's understanding within their department what changes are happening from a coding perspective. Now, sometimes this isn't just an isolated thing that everybody has to take it on themselves. This would be where we figure out maybe a process around how are we going to do the annual updates and communicate that. A lot of organizations, use the coding department to help with that. And then, actually providing them with tools, things like out of this, going over things with them in the updates and the CPT book, so they understand what those changes are and how they might impact the organization. And again, as I mentioned before, it's not only updating the Chargemaster, but anything that is related to how we capture that charge, be it a paper charge ticket or a charge screen in the electronic system, and it's a good thing to go through periodically with them, to have them, not only them, but whoever's kind of doing your Chargemaster coordination, just to see, is this capturing everything? Are we missing things here for you to capture? I was recently at a facility, and their charge ticket, if you have to write a lot of things in there, odds are you're going to miss stuff. So the more you can include, the better. I realize that you don't want to have like 10-page charge tickets or multiple screens to capture those things, but try to see how you can make sure that you're getting most of the charges in a mechanism that we're able to capture them. Another thing that we say for departments, and we'll ask them, what are they doing to reconcile their, charge capture, if you will? It's one thing to say that you're responsible for charge reconciliation, but then if you don't really have any tools to help organize it or help the departments do that, that makes it kind of difficult. Also, if there's no expectations that have been communicated, and frequency, and maybe you have a few areas that actually do this really well, and maybe they can be the champions for the organization to kind of show how they reconcile their charges. Some people have been doing this, managing their area for quite a while. A lot of times they'll go back to something that they had been doing maybe before they went on this electronic system, and then pulling just sort of what looks like a revenue and usage type report, be it maybe if it's daily, if that makes sense for them, weekly or monthly, just to check the reasonableness of the charges. So it's a conversation and an expectation that should be discussed in your organization as to how, how you want that to look, and to make sure the departments know that that's something that's expected of them. So best practices for Chargemaster, we spend a lot of time talking about the policies and procedures that should be within the organization. And, for starters, obviously you need, a Chargemaster, the things that relate to that, management of it, the maintenance of it, who's going to be doing it. Also, I just mentioned the charge reconciliation, and also who's responsible for charge capture. Another one we mention is room rate policy. What we run into is a lot of times it's like, what are the different room rates we have? Sometimes they have not looked at the room rates for a while, and we see some kind of outdated room rate setup that they're not using. And then are we including things, kind of things that are supply related that every patient gets in the hospital that maybe we're bundling, just to speak to what is included in the room rate. So what types of room rates do we have, and what's included in the room rate? The next thing would be an observation policy. And again, it's how do we charge for observation? And, it should mirror if we have 2 room rates as an example, one just regular room and board, and we have another one that has monitoring attached as an example, that we should have the same type of observation rates that would correlate to your room rate. We'd also talk about, do we front load, the first hour or the first couple of hours, and the other thing that I think is worth having in this policy is the discussion around the carve out for those, what the process is, how often we're looking at it. And that's for when you go, the patient goes and has a procedure or something else, whether in observation that we're charging for, outside of the observation rate. We have to have a process around how do we carve that out, so we're not charging for observation while they're having a procedure done someplace else in the organization or in the facility. Supplies is another area that we should have a policy around, and this is where we're looking at what is the minimum charge that we will set up for supplies. What's the markup policy? And again, all these things should be looked at annually to ensure that we don't have changes that occur, or they're still meeting the mark and what we want, want that markup to be. Pharmacy is another, similar to the supplies. Again, are we charging like for every Advil, Tylenol, or are we just gonna, kind of bundle that in somewhere, as opposed to having a lot of different little charges? It's worth mentioning and talking about your policy around, take-home drugs, self-administered drugs, and again, the formulary around pharmacy, and just around the process. And you get your cost data monthly and then you apply these markups then? How does that work? When we talk about modifiers and CPTs and HCPCs, a policy around your annual update process. What does that look like? Who's part of that? What things might be hard coded in the Chargemaster versus soft coding that needs to go to through to the coding department to actually add the code, any markup around that. And then surgical procedures. what's the rationale that we used for charging? You know, how did we come up with our, if we do a base rate and then a per minute rate, how were those established? You know, the charge itself, just things around the OR anesthesia and the PACU. And then what happens if we have to have a patient who's not ready to go home after hours? You know, and if they go to the floor, is there a way for the floor to capture that time when they're in recovery? And then pricing policy. And again, this is in red because we'll be talking more about that in a few minutes. Kind of correlates with the charge that was in red before. We have to mention that there is a component of the Chargemaster and how it relates to the cost report. So one of the key things is, of course, matching. You know, we want to make sure the costs are in the same departments as the revenue. So I kind of talked about the importance of matching and routing charges to the corresponding expense account. Now, sometimes we aren't able to do that. Not necessarily the charge piece, but sometimes the expenses are in like multiple areas. And we tend to see this a lot with like EKGs, cardiac rehab, sometimes too, because like with EKGs, we might see that nursing does it. We also see it that it might be done in radiology sometimes, in the emergency department. And so we have these costs in like 3 to 4 different areas, but we have one maybe revenue department where that charge is. And so how do we get that expense reclassified or tracked during the real time, be it, you know, it's swiping in and out from a payroll perspective. We want to make sure that the costs and the charges are in the same area on the cost report, because it drives this cost to charge ratio, which then sort of is kind of the basis behind how we get paid ultimately for Medicare on our Medicare charges. And it also shows the personnel that are involved with the Chargemaster should understand that this is a thing that needs to be communicated to whoever does the cost report. If there's changes that happen with who's providing these services, that individual or company knows about these types of things so that they can adequately make sure things that are the expense and the charge overall are in the right spot. The cost report preparer may actually ask you, based on when they kind of get your data to prepare the report, and they see things showing up in multiple departments, kind of like the EKG example. And, you know, or supplies is another area where we see multiple charges in different departments, and how do we address that on the cost report. And this is just showing what I was just describing. So, you know, in all of these situations, we have, you know, your overall cost, say for the operating room or radiology, and then we divide that by the total charges for those, you know, the operating room. And we come up with what's called the cost to charge ratio. And that cost to charge ratio then is applied to your Medicare. It's multiplied times your Medicare charges. So if it was $10,000 of Medicare charges for the OR, and say you had a 50% cost to charge ratio, your Medicare reimbursement would be $5,000. And that revenue code is 360 for the OR. So that's how we would then pull and identify what are the Medicare operating room charges. We then look at the revenue code, as opposed to on the claim side, and in the, you know, you're looking at more with the coding and CPT codes. Ultimately, the rev code would be on the bill as well, and that's how we get that information. And then the 320 and 350 are radiology related revenue codes, and 250 versus 636 is pharmacy, and 270 would be supplies. So I kind of already chatted a bit about the common matching problems that we have with expenses not transferring to the correct cost center or department where the revenue is being generated. Same revenue codes, but they're in multiple cost centers, like the supplies. You can see that in different areas. And also, when you have services like IV administration and blood administration, where we have those things being done maybe in nursing, in the emergency department, and or if you have an outpatient services area, well, it's how do we get that then, to be reflected properly in the cost report. So let's talk about some Chargemaster success factors. So what are some ideas to keep this Chargemaster current and successful? Well, I've talked about a few times about an annual update / review of the Chargemaster that covers all departments. It would be looking at CPT code changes, and then also pricing. And is the pricing where we want it to be? And we'll talk more about how facilities address pricing and maybe how they might start having a strategy around pricing for services. Do you have some sort of a Chargemaster team? Maybe it's part of a revenue cycle committee, and maybe a lot of the times at your facilities, we're not talking a huge amount of people. We're talking to maybe about a handful of people that would be part of this group. So if you already have some sort of a meeting where you may be talking about denials or compliance or revenue cycle, it's something that could be incorporated into that same group of people, and that it would be something that's planned and discussed during it, at probably the time just right around when the CPT codes change. This would also be something where you maybe could bring new services that somebody wants to start providing and have that conversation of what it might take to do that. So usually what we see on that committee would be the individual who serves as your CDM coordinator, somebody from the business office, coding representative, finance, IT, and compliance. When there's a system upgrade or conversion, it's really wise to, look at, like if you were going to upgrade or convert to a new system, a lot of times organizations will have their Chargemaster reviewed prior to that to clean it up, if you will, if they think there's could be some potential huge amount of codes that they don't really use. You want to make sure you have a kind of a clean Chargemaster going into an upgrade or conversion. And maybe then do something post-implementation to see, did everything work out the way we intended it to? Do we have any issues with things being set up inappropriately on, in the Chargemaster itself? And then, do some periodic monitoring and auditing, just of some of those areas that are, what I would say, more complex, higher risk, things like the infusion, hierarchy, observation. Those are the areas that seem to be the more complex and complicated and, require a lot more thought and skill set around, how do we code and charge for those things. So ongoing maintenance, make sure you have some sort of a process in the organization to review, newsletters from payers, you know, who's getting the local MAC updates and the transmittals and CPT changes, and how do we go about making sure people know what's going on. It's another area within maybe that committee that can talk through some things that might be impacting your facility. If it's something for lab, do we have somebody who then sends it off to the lab person so they know what's coming up, maybe some change in a policy from a health plan. So just like who ensures that the changes are getting made if something is applicable in a newsletter. And that's, again, maybe if you have that committee, that's a good place to have that discussion. So we have change form in quotes. This is about what the process is. Identifying things that we know we need to add something here, or I need to delete something, or we're not using this charge code. Do we have a form? Do we use something within a software tool that allows us to request a change and add, change, or delete? Just to document what that is. Sometimes some organizations, it works just fine for them to have an email chain, but then to keep that information, so should anybody be asking a question down the road, why did this happen, or why did we change that, there'd be some documentation to support that. And then making sure that everybody's on board with maybe what a request that is being made, and having that group again kind of look through some of those, be it the department head, the coding people, the Chargemaster team or director, and finance and compliance. Making sure that you have all of the current reference manuals, like are you getting, and people know who has them. A lot of times people don't really understand that, oh, well, the coding department gets the current CPT and HCPC books. So if you have a question, you can go to the coding department. And also, the other resources would be the uniform billing editor and just some specific department reference manuals. Maybe radiology wants to have something that they've been using. They've got a resource that they've used over the years that has been very helpful for them to keep current on what's going on with their service. And then what's the process? If we're going to have every department get a CPT book, how do we manage that? Does everyone need, a copy, or can we just reference the one couple in the maybe coding and billing area? And then maybe taking advantage of, discount pricing by if we're going to order more than one. And what's the appropriate number? Everything may not be showing accurately on the claim form, even though it's correct on the Chargemaster. And why would this happen? This is where I have my thoughts around, a lot of organizations, we've got a team of people managing the Chargemaster. I have this tool that I can use that's making sure everything's updated and clean. And what I will say when we do our Chargemaster reviews is that you could have the best looking Chargemaster, it's accurate, spot on, but where we usually find things is in what I'm suggesting here is a periodic audit, or in what we do is a little charge capture review. So this would be looking at inpatient and outpatient and professional claims, just to do, periodically, maybe on a quarterly basis, and not a huge amount, but to just kind of look at that to see that, is the documentation supporting what's been charged, and do we have the proper codes and units. One thing to look at is if you have any high dollar or high volume drugs, to kind of focus and look at those periodically throughout the year. I talked about the observation carve out, as well as the units. Are those being done properly, billed out properly, as well as drug administration and infusion, IV hydration. Those are all kind of areas where we tend to see pitfalls in, how things are being charged ultimately on a bill, and maybe having some potential issues there. The other thing I have here is the emergency department professional, actually it should say facility and professional bell curve. That is something that is really easy to do, and I'm always surprised at how many places we go to don't really look at this on a regular basis. So all it would be doing is taking the utilization for those 5 levels on the facility side, and if you're doing the billing for your emergency physicians, seeing what the utilization is for that on the professional side for those 5 levels, and to see, where that shakes out, and do you have kind of more of a bell curve. What we've seen in some instances is that, and they're not going to mirror exactly, but some of the organizations are using their electronic record or system calculator in the background for their facility charging, and they don't really know how that's being calculated. We've seen a bell curve that actually was a straight line going from the level 1s were very low to level 5 being the highest volume for facility. And they had never done a bell curve just to see. And so it's very easy to do, and it's just something, and there's explanations as to why maybe you don't have a lot of lower level visits. Maybe you have an urgent care. Well, that might make sense why you wouldn't have a lot of level 1 facility charges. So just another quick little tool, or not a tool, but a little quick analysis to see, do we have any issues here potentially? And if you think you might, then from that data, maybe you can have somebody from coding do a more focused review, and or maybe if you are fortunate to have a nurse audit resource, that would be somebody to utilize in that as well, and then provide education as needed around that. So I put nurse auditor and coding resource here. I mean, not everyone has that luxury to have that within their hospital, but we have found where we see the best results, when we've done some of the Chargemaster reviews over the years, when we've seen a real engaged compliance function as part of the Chargemaster and throughout the organization, that actually has some involvement with coding and or has some sort of a nurse audit function. That's where we see the best, the cleaner Chargemasters. We don't see a lot of charge capture type issues. We don't necessarily see a lot of, documentation not supporting the charge. So something to consider. Maybe there's someone in the organization, and it just depends where the resource is that you maybe you don't have a nurse auditor, but you could have somebody in coding potentially help with that. So what do we do when we do a Chargemaster review? And basically, we just ask for a few pieces of information. We ask for your Chargemaster, and we ask for the revenue and usage information. And usually we will look at the last fiscal year of utilization and then the current fiscal year to date. And what we're looking for there is to see, are there a lot of things that we're not using? Now, sometimes we'll just be getting we actually are only provided then active codes, so that kind of doesn't help in that regard. So once we get that information, we then merge the two files together. Some of the software that hospitals are using, they're able to actually provide us that in just one like Excel file, but others they can give us stuff out of their Chargemaster, and then they can give us utilization in a different file. And so we just generally merge the two files together, and then we upload that file into a tool that we use here at the firm, and it does what I call a compliance analysis. So it just scrubs it to see, are there inactive or not inactive, are there deleted codes, invalid codes, things that, maybe it says that this is not a Medicare recognized code, CPT code. And a lot of times, well, yes, we know that that isn't, but we need to still use that code. But it just prompts us to look a little further into those sort of variances that they identify. It also look at if there's the same CPT code, but they have a different price, that gets identified in that process. And then we also review a small sample of outpatient encounters, anywhere from 20 to 30, where we look at the chart and compare it to the detailed patient bill, and then ultimately to the UB claim form. And that's where we're kind of looking to see if there's any potential charge capture issues. And based upon what we see in the compliance analysis and this charge capture review, that drives a lot of the conversation that we have when we have the interviews that we set up. So we then meet with all of the charge generating clinical areas to understand where they sit understand their process around charging, keeping up to date on things, updates and codes, and if they do a charge reconciliation. And we also allow them time if they have questions around anything, like they're curious if it's something that they do, can we charge for it? Then we have those conversations as well. And as I said, the pristine CDM may not correlate to missed charges or claim areas, and that's why we do that charge capture review. And I have to say, I think organizations really find the interviews very helpful, and it's something that can be emulated within your own organization and maybe during the annual update process, because it's like one of the few times that all of the players are sitting together and talking through what goes on in the clinical area, who is, a lot of times we'll hear things, well, I thought you did that. I thought you coded that. Oh, I'd have thought that came through on the Chargemaster. And so it's just sort of, it becomes an educational thing for everyone involved. As also in those interviews, we pretty much have the Chargemaster person at all of those meetings, coding, and somebody from billing and compliance, if you have a compliance person.
So we're going to do our first polling question, and that's, how long has it been since your organization had a Chargemaster review?
So 23% within the last year, and about half of you within the last 1 to 3 years, and there's some out there that it's been maybe more than 3 years. Okay, great, thank you. So now we're going to talk about the charge analysis, or sometimes we refer to it more as pricing analysis. So I'm not going to spend any time on this slide right now, but I just wanted to show you that there's some keywords that we're going to talk about when we talk about the transparency. And you see that charge and price, again, are in that, that conversation. So we've already talked about the Chargemaster review, but a lot of times when we're talking with clients, they say, well, I think I need a Chargemaster review. And then when we talk further, we find out, well, they really just wanted to see how their pricing of the services, the charge amount, if that's where it needs to be, or we're, you know, in line with their strategy. And basically, doing a pricing study or charge analysis, and I'm just using the words charge to prove a point, to have consistency in terminology, if you will. But this would just, it's a means of validating your strategy, that it's being executed the way you wanted it to be, or it may actually help you develop a charge strategy. But some of the downfalls is that if you don't really do this in conjunction maybe with the Chargemaster review, when we do the pricing study, we're assuming that all of your codes are being utilized properly. So if something's being done and it's not being captured properly, well, we're not going to capture that in this study. So there is some benefit to having it done at the same time. So we also ask for the same information when we're doing it, although we want it by financial class, the revenue and usage, because we're going to be looking at kind of payer mix, and if there's some other more commercial things that are, you know, if you have a couple commercial payers and maybe where that price sensitivity might be present as it relates to those commercial plans. Your hospital Chargemaster, we then ask for MedPAR data, and then you would provide us with, you know, anywhere from 6 to 10, or how many, you know, 10 probably is more the cap, but of the facilities that you want us to include in the data for market comparisons, you know. And what we find is, in order, it has to have like a HCPCS or a CPT code, and it has to have had more than just a few units of utilization by the peer hospital to produce valid data. And the MedPAR data does not have room rates, but you can obtain these from other sources. I know in Minnesota, the Hospital Association here does have inpatient room rate data, and we can utilize that data. But we can also, when we're doing that, if you don't have that for your state, we are able to sort of back into that and figure out what that might look like for those peer hospitals. And then our deliverable is a spreadsheet tool, if you go that route, which is a comprehensive type study. And it's by department, by charge code. You're compared to all your peer facilities that you've selected. You're able to do what I call what ifs. You know, what if I move this to the from 50th to the 75th percentile, or I hold this actual one line flat? What does that do to my overall increase based on where you lock down? You know, say maybe I don't want to change a price because it's something that I'm not going to be competitive with, knowing what I know about my market. And then you can actually document how you landed on your pricing for, you know, you could even get down to the charge code level. So some of the things that we, you know, I talked about the same CPT, different pricing. Well, there might be reasons for that, like in radiology, where, you might have multiple views, but it's always going to be with that same CPT code. And obviously, one view would be less than a 2-view, 3-view, 4-view. There's a differential there that would make sense that you would have different pricing for the same CPT code. Also, I've seen when you have a procedure, you can have one with the contrast, one without, and you could have one with and without, but they all use the same CPT code. So again, another instance where you would have, different pricing, but the same CPT code. Lab's another area, and, lab can have its own structure of how they price. Pharmacy and supplies, we tell facilities we pull those out of our analysis, and it's because they have their own pricing structure, markup structure, and some of these things don't necessarily have a CPT code anyway to compare to, so that's another reason why we exclude that. But it's important to understand how that is being done behind the scenes. We make some general assumptions with some of the commercial payers. If you're paid on a percentage of charge, that's pretty easy to, understand how that compensation works, but it will validate that with you so that as we're going through and you're seeing what if you're doing some of your what ifs, you can see how that impacts that. And again, we assume that the charge codes are utilized appropriately, and the peer data that we get is usually a year old. So we usually put some sort of a markup that we apply, be it 3 or 5% usually to get, say, up to more what the current prices or data would be with that, to get us uncurrent with from 2017 data and get us into the 2018 time period. And then we know that some of those CPT changes happened in 2017, and 2018 might be a little bit different in some cases due to those changes. What do we mean by a charge strategy? So you want to be what we have a defensible pricing strategy. So this is where I say that, I think pricing is not easy. I'll just say that. There's the number crunching exercise that we can provide you, this spreadsheet tool, but it's a tool because then there's the art behind pricing. So it's, a lot of number crunching, but you can't just say, I'm just going to give everything to the 75th percentile, literally. Sometimes as you're going through that, you might say, oh, that doesn't make sense. Or I know we get a lot of complaints on this one. I don't want to change the price. I do think the department should have some, understanding of how the pricing works for them. They may actually have some good input as to maybe keeping certain things, holding them flat as opposed to marking them up. But what I say is that pricing can be based on market, where if I want to be at a certain percentile of the market, it can be cost plus a markup like we see in supplies and pharmacy. And it could also be based on what we're getting from our highest, reimbursement from a health plan. Because if we have any sort of provisions in our contract that you get the lesser of your charge or your contracted rate, we don't want to run into those situations. So we always want to make sure our charge is at least a little higher than that contracted rate for those types of situations. And I've already talked about some of those areas that have unique pricing. So would say that you should have a pricing policy, and this is basically defining your strategy around pricing. It's going to define what that strategy is, and it can be as simple as, our pricing can be set based on the market or cost plus a markup, just those same things I just listed above that. Also, it's a good opportunity to put in what are the markups in, the supplies. If the pharmacy isn't too complicated, generally speaking, what that looks like. Lab, if it has different rationale for how those lab prices are set, that should be defined in the policy as well. Or if there's any areas of exception, what are the annual price changes, interim price changes, if any, how does that work? And new services, what's the process around how we figure out what the price should be for that? So as I said, it's important to engage the departments in the strategy, as they may know more about the market up for their services. Have we gotten any patient complaints? Is there some things that just seem to be more sensitive to that, and maybe we need to spend a little more time looking at what we want to do with those types of things? As I said, that tool, if you have that, will also help you. You can document why you ended up doing what you did when you adjusted the price, so that if anybody does question it, you can at least defend what the price is, even though they may not be happy with your answer, but at least you have what your defense is on that. You might be limited on an overall basis, because some states I know have where you can only increase the your charges maybe say 3% a year. Of course, that's on an overall basis, so maybe you can look at things where maybe I can increase something higher here because I really need to do that, and then not do anything. Or sometimes places might even decrease the price for given reasons. Other things to consider too is some of your contracts with health plans might have so many number of days that you need to give them a heads up for them to be okay with the fact that you're going to increase your prices, say, on an overall basis by maybe 5%. This analysis should be done in alignment with the annual budget process as well as contract negotiations, so that we're aligning and the timing works out with that. And then engage with, the Chargemaster coordinator and coding to assess updates that may impact revenue from a budgeting perspective. There's been years where radiology's had a lot of changes, and I've witnessed this myself, that the budget people didn't know that now something was going to have. We had 3 different charges for, but now we can only have 2. And did we reprice those things appropriately so that we didn't end up with a big hit to, our budgeted revenue for that given area?
Does your organization have a formal charging pricing policy?
Okay, so it's about 50-50 having that. Okay, it's great. So now on to pricing transparency. This has been around for a while, but I'm starting off with HFMA, the Healthcare Financial Management Association, actually has a price transparency brochure, and I've got the website for this. And I pointed out because they've had a task force for years, and they've spent a lot of time on this. And they encourage organizations to feel free to download this and have a link to this. It's another way to maybe provide, some information to your patients that might simply explain some of these terms that we use when we're talking about pricing and charging. And so if you remember that slide I had at the very beginning where I talked about, and I had things in purple and red, the charge and price and cost are some of the things that I think it gets confusing for people, and it depends who the person is that's asking and wanting to know what that means. HFMA's definition of pricing transparency is that, in healthcare, it's readily available information on the price of healthcare, helps define the value of those services, and enables patients and other care purchasers, which again is a term now out of this pricing transparency thing defined by HFMA, what a care purchaser is, and others to identify, compare, and choose providers that offer the desired level of value. So, the word charge, they've tried to use as the dollar amount set for services provided prior to any negotiated discounts. So that's the amount we would see in the Chargemaster as the charge amount. And that's the dollar that we're looking at when we are doing our pricing or charge analysis. What should that number be? And then the price is what they're defining it as, the expected payment for the service provided, which is dependent upon whether one is insured or not. And then the cost, they say, obviously depends on who is the party, asking. From a patient's perspective, the cost is the out of pocket for them, whereas the provider, the cost is the expense of doing the service. So pricing transparency actually was discussed and was included in the ACA, but it wasn't until the 2015 IPPS final rule made it, more something that they started to put some rules around. It wasn't very specific in that rule, and you could comply with their pricing transparency requirements just by merely having a link on your website, maybe to some hospital association data that would have some of those like top 20 or top 10 types of charges for procedures. But now we've got the 2019 IPPS final rule. And yes, it's the inpatient prospective payment system where they've inserted this. And, since they did it in 2015, that's where you will see it again going forward as they tweak this. And I'm anticipating this isn't the last time we're going to see this stuff. So what this rule says is that you must post your standard charges on your website. It's effective January 1st of 2019, which is in less than a month, and it must be in a machine readable format, i.e. no PDF files, and it needs to be updated at least annually. So some additional considerations. There's been lots of conversation on this, and not a whole lot of guidance other than, as I've pointed out below here, the link to CMS's frequently asked questions. And in there, that link does say no hospital is exempt from this. So it doesn't matter how you get paid from Medicare. If you're a hospital, you need to comply with this 2019 rule. And that the state online postings do not exempt you from individually posting on your facility website. They only just really say that your standard charges, but what does that mean? As you would see in your Chargemaster. So some of the things I would caution as you are doing this, and many of you maybe already have what your strategy is going to be for this, but really I think the motto that from what I've heard around here in the Minneapolis area is less is more. So, I had been at a conference early in October, and it was a revenue integrity symposium, and that already were people are saying, do not put CPT codes in and do not put revenue codes out there because they're proprietary. The other thing I've heard is you have to first get over the fact that, yeah, this isn't helping patients, but we have to do it. So just accept that it's not going to help patients, but we have to do it. So to me, it almost seems like you need to have some sort of a rationale, policy, procedure, if you will, around why you did what you did when you posted it on the website and what your process is, for updating it, those things that they're looking for and what format you chose and why, as far as the machine readable format. Be aware that some states may actually have some more requirements that you need over and above the federal requirements. There might even be something that applies to clinic visits and things and clinic prices that is outside of this hospital requirement. So just be aware of that. I know larger organizations struggle with just the pure volume of what they might have to post. When you, the CDMs outside of the main provider or main CDM, when you've got pharmacy master, you might have a supply master. I have heard around here that some organizations are very cautious to maybe post that type of information, especially if you do some implants, because they're afraid that it might violate some of their purchasing and contracts they have with these device companies, because people could back in and figure out the pricing. I have a feeling that there'll be more to come on this. This is step one. I think CMS, again, this is my opinion, not Bailey's, it's my opinion, but definitely once they see what gets posted, there might be more that they're going to ask for or for clarification purposes. So this is the last polling question. Okay, well that looks like we've got 67%, close to 70% on track, which is great. And then just a third not set yet. So we're at the end of the presentation, and I know I spent a lot of time on the Chargemaster, but I also wanted to demonstrate to you, there's the Chargemaster, there's a charge analysis, there's pricing transparency, we got to post our standard charges. I hope that I was able to provide some more clarification around that. I hope that people, if they feel somewhat lost, sometimes when they're doing pricing and charge strategy, that maybe it's something to think about what that might look like going forward, but that you're probably not alone in some cases as to how you approach pricing. Hopefully you've learned a little bit about the fundamentals and the benefits of each one of these things. That an updated and effective Chargemaster will streamline the billing process and gain efficiencies and hopefully more dollars. And also the importance of maybe having some monitoring and compliance function engagement that always seems to make things seem to go more smoothly for organizations. That there's, cost reporting, payer contracting and budgeting things that need to be considered as it relates to all of these things. Changes in the Chargemaster, how might that affect the budget going forward? Do they know about it? Same thing with charges. And then the need for structure around the Chargemaster and how charges are, the dollar amounts established, the strategy, being transparent, defensible pricing, and then the core policies that were suggested. It's a lot of policies, but they're they're encouraged, because I can't tell you how many times we get to places and they're like, well, I think we bundle that, just to have it, and it doesn't have to be real complicated, just to have something to document what we're doing. And then the setup for success for compliance with the January 1st, 2019 transparency requirement. And, you know, it's, if you can at least post your charge and the charge amount, or the charge and the description. There's been discussion about people or places here in the cities that maybe aren't going to post their charge code even, and that's where the less is more. But that, again, that's what this community's been chit-chatting about here. The Hospital Association here in Minnesota actually has had a pricing task force to talk through this exact thing. So I'm not sure if in the areas that you're located, maybe there's been conversation at that level as well. But as I said, I think this is step one. Actually, step one was the posting the link to the Hospital Association, if you have that. This is step two, and I do think it'll be more to come. So I thank you for participating, and if there's any questions, we will certainly circle back with everybody to ensure that we do, since we didn't have time for any today. So thank you.